My name's Dr Michael Dixon. I'm a GP in Devon, seeing patients 3 days a week, and 2 days a week I'm chair of NHS Alliance, which represents the new GP clinical commissioners who are making decisions as to what sort of treatment you have. In fact, for the last 15-20 years, with various colleagues, we've been developing clinical commissioning and pushing successive governments for the right of GPs and frontline clinicians to make those decisions on behalf of patients. And finally, with the white paper and the recent bill, that's coming to happen. And that's what I'm going to be talking about today. GP commissioning was renamed clinical commissioning during the passage of the bill, and it's very new because for the first time ever it puts frontline family doctors in the deciding position as to what sort of services you receive as a patient. Now, that's never happened before. Previously, the NHS has been run by senior managers, often answering to orders from Whitehall, and not necessarily putting you as a local patient first, not necessarily knowing what you needed, and not necessarily being able to actually action that. So I think it's emancipation time for frontline clinicians, but it's emancipation for their patients, working with them to decide what's best for them. The new Act does allow both private and NHS providers, which is new. To some extent, although we have used private providers in the past, there'll probably be more private providers used. But the decision as to what sort of services will be available will be the responsibility of a family doctor working with local patients like yourselves in communities. So how much private will depend upon how much you want, and that will depend upon how good the service is. Now, most of the time, NHS services have historically been very good, but we've heard about hospitals in the north of England where sometimes they haven't been quite so good. And therefore, where the service needs improving, it's quite reasonable that your local commissioner, that's say your family doctor working with the local population, to decide to go elsewhere. There won't be any ideology about this, and I suspect that there won't be a massive change in the sort of treatment you'll have. Most of your care will still be with your local hospital, but sometimes when the treatment can be offered better, perhaps closer to home or a more specialist facility, sometimes it may be private, but that will be the decision of the family doctor and the decision of the local population. I think we are in for dramatic change this time, because what has changed is that clinicians are statutorily being asked to lead these new statutory organisations responsible for the sort of care that we get as patients. That's not happened before. Before, we've had bureaucratic organisations which have been led by often very good managers, but acting under orders from managers right the way up the system, who have therefore had to dance the tune of this hierarchy. In future, it'll be your frontline clinicians working with local managers, working with local people, making sure that those local priorities are met, and responsible at the same time as enabled to make those changes happen. So there is no way that the clinicians can be sidelined this time, and with 4 or 5 changes beforehand, it's always been possible. It's not possible this time. I think clinicians and the public probably need to know more about why we need these reforms. I don't think that your average clinician or even your average member of the public really understands what they're about. And of course, they've heard the politicians on both sides. From my point of view, I think the reforms are really quite simple. In 1948, clinicians like myself joined the NHS and provided services which were free for patients. But we were not really involved as part of the NHS in terms of making the best use of resources, in terms of being enabled to decide what services our patients had. I see this as almost the next stage of NHS reform from 1948, finally emancipating clinicians to decide what services their patients get, emancipating patients to work with those clinicians to make those decisions. but part of power is responsibility. And my decisions in surgery every day in terms of who I refer, what tablets I give, what diagnostic tests I order, all have cost implications. But I need to take responsibility for those collectively with other clinicians, because at the moment we have a system where some clinicians are spending far, far more money than others, and sometimes that's not well spent. There might be diagnostic tests not required, there might be referrals that weren't necessary. The effect of this change would be to make sure that we use those resources better, that patients get better care, but that it's more fair, and hopefully that we create a sustainable NHS, because if you look at the spending as it is at present, it's not sustainable. That's why the reforms were necessary. We've talked endlessly about patient choice, but I'm not sure we have really delivered real patient choice. Currently it's limited to the hospital or consultant you go to once, if you like, I as a GP have decided that you actually need to go to a hospital. But that's not really real choice. The real choice comes far before that as to which GP you register with, and then having registered with a GP and making those choices with him or her, what you do about, for instance, if you've got an injured shoulder, do you have an injection, do you have physiotherapy, do you have tablets, or do I show you things that you might be able to do for yourself for it? That's real choice. And real choice is also about being able to define the different choices available. In surgery today, yes, you have choice, but only from the menu that's there. What the reforms are doing is they are taking clinicians like myself and patients like yourself out of surgery and saying, you can decide what menu is available in the first place. And so if you can decide what the menu is, and you can decide what you choose from the menu, then you've got real choice. And I think that's exactly what the reforms will deliver. The importance of having primary care clinicians on the National Commissioning Board is because the imperative now is to try and move services from hospital wherever possible into the community, closer to home, because they're better, they're easier to access and less expensive, and also wherever possible to deprofessionalise treatment, to enable patients to look after themselves and perhaps not even need professionals in the first place. Now that requires primary care clinicians to advise on that. And the problem in the NHS historically has been that if you went to Richmond House, where the Department of Health rested, all you had was senior managers and senior clinicians, all who came from hospitals. And that's why in the UK we use hospitals more than any other country in the world apart from America. That's got to be reversed, and the only way you can do that is by having primary care clinicians, GPs, nurses in the community in the positions of power, right at the top, making sure that we redesign services so they are closer to home, so that everyone isn't always going to hospital. We must get the balance right between localism and centralism. We haven't done it to date. To date, the NHS has been described almost like the Kremlin, with orders coming down from above, everyone keeping the orders, but sometimes ticking boxes rather than looking after patients. And of course, the media is full of examples of just that. What we now must do is to get a much better balance so that the local people, local needs are met, and local clinicians feel that they're able to give their patients what they need and want. To do that, these new clinical commissioning groups will need to concentrate as furiously on keeping contact with their local patient population and the clinicians in their local GP practices as they will, if you like, feeding the beast and the orders coming from above. Now, I'm quite confident that will happen because we've had a managerial hierarchy in the past where each manager down the line has had to obey the manager above because he or she decided whether they kept their job or not. With clinical commissioning it's different because the clinician themselves is an independent practitioner like myself. I've got a job as a family doctor, so in a sense I can't be unseated in the way that happened before. So I believe clinical commissioning will create that new balance that we need between local and central. My organisation, NHS Alliance, believes that patients should come first. Now, I know we have many senior managers and politicians saying that, but we really do believe that. And if patients come first, patients must come first in every sense, not only in helping us to make those clinical commissioning decisions I've been talking about, but also in terms of their own care, in terms of looking after themselves, in terms of their records. And the new changes will enable patients access to records. Of course, they do have access to them already, but I hope that we'll take that process a bit further, where records will be shared between doctor and patient, and where if a record shows something that actually hasn't happened or needs reinterpreting, the patient will work with the clinician to do that. We need to make health the responsibility of the patient, not of the record keeper, the doctor or whatever. And part of open access to records, I think, is emancipating patients to look after themselves ultimately and to take responsibility for their own health. And until the NHS does that, it won't be financially sustainable.